Morning, everyone. As a bit of background about Dr. Schulert, he completed his BA at Kenyon College, his MD PhD at University of Iowa, and then was chief resident in Pediatrics at Vanderbilt. In 2013, which is not that long ago, he moved to Cincinnati and became a rheumatology fellow and had the opportunity to work with the wonderful people there. And he's now a faculty member and is actually co-director of the Autoinflammatory Disorders Center at Cincinnati Children's. For those of you not familiar with that term, it's not the same as autoimmune disorders. And we do have a grand rounds from a couple of years ago on this topic. If you look in Wikipedia, you may not still understand it though. The focus of his research is on the pathogenesis and novel treatment of inflammatory disorders. And in this role, he's taken on some of the most challenging and frankly, anxiety-provoking problems that patients, parents, and providers in other pediatric rheumatology centers face. And so he's become an incredibly valuable asset to our international community. So in addition to all the work he's doing to advance scientific and clinical knowledge, he has a notable record of service to our profession. And I think today's Grand Rounds will be another example of how he's bringing our field forward and helping people around the world. So I want to thank Dr. Schulert for sharing his thoughts with us today.
Well, thank you, Dr. B, for that kind introduction, and it's very nice to be in the Twin Cities virtually. I'm sorry that I can't be there physically. I'm a Midwesterner and I have great memories of visits to the Twin Cities. Plus, it sounds like you guys have much nicer weather than we have this morning. In Cincinnati, it's foggy and rainy, so hopefully the nice weather that your chair described is on its way to us. I'm very happy to talk this morning about one of the topics that's been consuming a lot of both my clinical and research effort in the last several years, which is a relatively recently recognized chronic lung disease that we see in children with the systemic form of juvenile arthritis. Just a couple of quick disclosures related to personal fees, and then we'll very briefly be talking about medication treatment, which is largely off-label. So my objectives are first, just to give a little bit of background. Dr. V talked a little bit about autoinflammation, so talking a little bit about that and systemic JIA broadly. And then pivot to talk a little bit about the lung disease that we see in children with systemic JIA, how it's recognized, what its features are, what we think some of the risk factors are, and what we're learning about its pathogenesis. And then finally, I want to spend the last few minutes talking about some new data from our lab, looking at a mouse model of macrophage activation syndrome, which we think has implications for helping us understand the pathogenesis of lung disease and systemic JIA. So what we now call systemic JIA has been recognized now for over a century, and it was first recognized by Sir George Frederick Stills, who was England's first professor of what we now call pediatrics or childhood medicine, who in 1897 described 22 children with what we now call systemic JIA and was, of course, then called Still's disease. And it has had a number of names over the decades that followed. It was called systemic onset juvenile chronic arthritis, systemic onset juvenile rheumatoid arthritis, and then more recently with the advent of the JIA or juvenile idiopathic arthritis classification, it was now called systemic JIA. So systemic JIA is a very distinct and peculiar form of JIA, which we'll talk a little bit about here. It's defined in the JIA realm as a chronic arthritis, and by chronic, as rheumatologists, we mean things that have been going on for more than 6 weeks, diagnosed in a child under the age of 16, which along with arthritis, has this very prominent fevers, where they have daily fevers for at least 2 weeks, including a couple days of that classic quotidian pattern, which of course is it's like Board's magic words when you hear quotidian fevers. They're talking about Still's disease or systemic JIA, along with other signs of inflammation all throughout the body, which can be this very striking rash, which you see here on the lower right, which is always described as this sort of salmon-colored evanescent rash. Adenopathy, organomegaly, particularly hepatomegaly or splenomegaly, and serositis. Again, reflecting this very significant degree of systemic inflammation. So to consider systemic JIA amongst the subtypes of JIA, when we talk about JIA, when I talk to the residents and medical students about JIA, it's important to know that this isn't really one disease. These are really 4, 5, 6, maybe completely biologically distinct diseases that we group together because they have the shared feature of arthritis in children under the age of 16. And here you can see systemic JIA compared to some of the other types of JIA. And it has a number of things that are distinct about it. Its age of onset, it generally has a peak age of onset in the early childhood years with sort of a broad peak from about age 1 to about 10. It rarely presents in infants, and it's less commonly presenting in teenagers and adults, but it certainly can. Unlike some of the more autoimmune forms of arthritis, like oligo or poly-JIA, which have a strong female predilection, systemic JIA has a relatively equal sex ratio. We rarely see autoantibodies, such as ANA or rheumatoid factor. We rarely see HLA-B27, as we see in the spondylar arthropathies. Rarely is there uveitis, as we see in other forms of JIA. There's not that sort of enthesitis or dactylitis that help define some of the other forms of JIA. And it is notable those strikingly high spiking fevers are a very unique feature of systemic JIA. Again, pointing to the fact that this is a very different beast than some of these other forms of JIA. So arthritis is in the name, right? So it's got to be a prominent feature of it, which it often is, but it's notable that arthritis can often be overshadowed by some of those features of systemic inflammation. So about 20% or so of children have sort of a mono or oligo articular arthritis, so one or a couple joints at diagnosis. About 40% or so can have a number of joints or a polyarticular presentation. But a fair number of them can have really no joints that are present at onset, somewhere in the order of 10 to 20%. And some of those will manifest some arthritis in the first months of the disease, but as we become better at recognizing and initiating early treatment, some of them really never present with significant arthritis. So just a little bit on sort of how we have treated juvenile arthritis over the decades. We can kind of break things into sort of the pre-biologic era and the biologic era. And then the pre-biologic era, we can really subdivide it into sort of pre-methotrexate and post-methotrexate. So up till the late 80s, treatment was really a number of things that weren't very effective and were highly toxic, things like gold, other sulfate antibiotics. Really, the pivotal trials of methotrexate really revolutionized treatment of JIA, but still, across the subtypes of JIA, there were pretty commonly bad joint outcomes up until the biologic era. And with the introduction of the anti-TNF agents in the early 2000s, we really saw a dramatic improvement in the outcomes of most of those non-systemic subtypes of JIA. But interestingly, systemic JIA patients in general did not have a great response to those medicines, which really revolutionized the life of children with things like polyarticular JIA. And it's only been here in sort of the second decade of the 20th century with the introduction of other biologics that we've seen a similar revolution in treatment of systemic JIA. So the question is, if these medicines worked so well for so many other autoimmune diseases, Crohn's disease, IBD, other forms of JIA, along with adult diseases like RA, why don't they have an impact on systemic JIA? And it turns out that it's because SJIA is really a very distinct disease. And we've already seen features of that as we've gone through this background. It's less of those typical autoimmune features. We don't see autoantibodies. We don't see that female predilection, which is often a hint towards autoimmunity. We see less often a sort of a general family history of autoimmune diseases. But instead, we see these distinct clinical features that reflect autoinflammation, fevers, rashes, neutrophilia, very high acute phase reactants. And then systemic JIA is also distinguished by this risk of macrophage activation syndrome. So let's talk a little bit about both of those two things. First, let's talk about autoinflammation. So autoinflammation is what we classically think of that as problems more with the innate immune system compared to the adaptive immune system, which is more linked to autoimmunity. So the innate immune system, remember, is our body's first line of defense. So it detects infections or signs of tissue damage, generally through these recognitions of patterns, conserved patterns from microbes or from damage or danger, these DAMPs. That leads to this sort of rapid and robust production of inflammatory cytokines, particularly things like IL-1, TNF, IL-6, and the interferons. Those cytokines then recruit and activate effector cells of the immune system and lead to removal of the infectious agents. In autoinflammatory diseases, we see that same pathway, but we see it sort of dysregulated. We see inborn errors or errors of the innate immune system, leading to activation by relatively minor or trivial stimuli, such as we see in like recurrent fever syndromes, or a failure to resolve and properly turn off that inflammation. That leads to a dysregulated production of those same pro-inflammatory cytokines, a persistent activation of those effector cells, and then the clinical features of autoinflammation. And really at the center of that axis are these cytokines of IL-1 and IL-6. And the activities of those cytokines really explains most of the clinical manifestations we see in systemic JIA. You know, IL-1, as we know, is sort of our key driver of the central fever response. It leads to activation of the endothelium, which can cause rashes and vascular activation. And then it triggers IL-6. And IL-6 is that big driver of the acute phase response in the liver, where we see elevated CRP, ferritin, serum albumin A, and then the driver of that bone marrow response, where we see the neutrophilia, increased platelet production, et cetera. IL-1 also affects directly on the bone and joint tissue and can lead to arthritis. And so it's really through the targeting of those cytokines, IL-1 and IL-6, that we've had sort of a similar revolution in our treatment of children with systemic JIA. And then finally, just to introduce macrophage activation syndrome. So MAS is caused by this excessive activation and proliferation of T cells, and particularly CD8 cells, as well as these well-differentiated non-neoplastic macrophages or histiocytes. And those macrophages in the tissue exhibit this hemophagocytic activity, which you can see in the bone marrow and the lymph nodes and the liver. And such is considered amongst the sort of the broad family of the hemophagocytic syndromes. And clinically, that manifests then as a systemic cytokine storm, where you see cytopenias, liver dysfunction, coagulopathy, and this extreme hyperferritemia. And even in sort of the modern treatment eras, full-blown MAS can be fatal in 10% or more of children. So in MAS, we've seen this reported really in association with almost all rheumatic diseases. The big players that we see it are in things like lupus and Kawasaki, mixed connective tissue, some of the monogenic autoinflammatory diseases, but most commonly it's reported in children with systemic JIA and adults with its adult form, adult onset Still's disease. Full-blown or overt episodes of MAS can occur in probably 10 to 15% of patients with systemic JIA, whereas more mild or subclinical or occult MAS occurs in at least 30% and maybe as many as 50% of children with systemic JIA. So with that as a little bit of background, let's pivot to talk a little bit about lung disease and systemic JIA. So prior to the 21st century, lung disease and in systemic JIA and Still's disease was relatively rarely reported. You can find case reports from the 80s and 90s, particularly if you search for the older terms like juvenile rheumatoid arthritis or Still's disease, but they were few and far between. And then descriptions such as this, where they see some parenchymal disease, a little bit of interstitial fibrosis, but really minimal abnormalities in pulmonary function, likely due to just sort of the chronic uncontrolled inflammation in the pre-biologic era when there was really no good ways to treat these children aside from high-dose steroids. That really changed in 2013 with the publication of a cohort led by Yuki Kimura through the CARA organization, the Childhood Arthritis and Rheumatology Research Alliance, which collected a total of 25 children with systemic JIA who had one of a number of severe pulmonary complications. Most of those were pulmonary hypertension. More than 60% of them had pulmonary hypertension, but a fair number of them had interstitial lung disease, and a number of them had alveolar prognosis, which we're going to talk more about. And as you can see, almost all of those children with lung disease had disease onset sort of more recently in the 2000s. So the initial thought was like, well, these are children who've just had, you know, years and years of under or untreated disease, but it turns out that's not the case. And what was notable about this series was that more than 2/3 of those patients had died by the time this was reported. So these were very significant morbidity and mortality associated with this pulmonary disease. And so we now recognize and describe this spectrum of disease as systemic JIA-associated lung disease, or SJIA-LD. Clinically, what we see is that most children who develop this don't seem to have lung involvement at presentation, but those signs develop usually in the first 1 to 2 years after diagnosis. And often the onset is very insidious. So sometimes there will be mild recognition of some shortness of breath activities, some chronic unexplained cough. Often it's sort of the almost incidental findings of repeated or persistent, quote, pneumonias. You know, these children will show up at a community ER, they'll have a fever, get an x-ray because that's what you do. They'll see an infiltrate and they'll say, well, you probably have pneumonia. I'll put them on high-dose amoxicillin. Won't get better. We'll say, oh, it's persistent pneumonia. Let's try a different antibiotic, or it's recurrent pneumonia. But it turns out that it's not pneumonia at all. It's lung disease. Probably the most common reason that this is recognized is actually the relatively abrupt onset of erythematous clubbing of the fingers and often the toes, which you can see in these pictures here. The one on the left a little bit more subtle, the one on the right a little bit more dramatic. Generally, children with lung disease have more of the systemic disease course, minimal amounts of arthritis, and in general have not really had reached a complete steroid-free remission on biologic agents. So quite a bit of knowledge about this has come out in the last 2 years from a couple of large case series. The first one was led by Vivian Saper and Betsy Mellons at Stanford, and included a number of co-authors, including myself and Dr. Behe, who included several of our patients in this series as well. This was a total of 61 patients with systemic JIA, mostly from North America, but some international cases as well. Most of them had this findings of alveolar prognosis, which was the predominant pathology in those who had biopsies. And we're going to talk more about what that is and what that means in a moment. Many of them had some sorts of reactions to medications or some concern for delayed drug hypersensitivity reactions. If you looked in sort of the prodromal period of sort of the 6 to 12 months before lung disease onset, often you would see this sort of smoldering and rising systemic inflammation. So you can see that here on the right. In the red line, you see patients who developed lung disease in this 12 months prior to diagnosis compared to systemic JIA patients who didn't. And you can see this sort of slow but significant rise in their serum ferritin as a marker for systemic inflammation in the period before lung disease diagnosis. In this cohort of 61 patients, their 5-year survival was only 42%, which is quite dramatic. Another interesting thing that fell out of this case series was both the increasing rates of lung disease being diagnosed in the last several years, as well as an increasing association of lung disease in patients who had already been treated with biologics. So similar to the initial case series, we were observing more patients being diagnosed with lung disease as the years go on. So both overall cases of lung disease and those with a biopsy confirmed cases of this alveolar prognosis. We're seeing more of those cases here in 2015 to 2017 than we saw in 2012 to 2014, as we saw the decade before that. Similarly, the proportion of lung disease patients that were in that was diagnosed in patients who had been pre-exposed to IL-1 or IL-6 blocking biologics increased from, in the first decade of the 21st century, about 50-50 treated patients versus untreated patients, to now the majority of those being found in patients who had been treated with biologics. Similarly, a number of features of this disease seem to be overrepresented in those patients who had been pre-exposed to biologics, particularly this sort of acute erythematous clubbing, this pattern A, which is this biopsy or this CT pattern of pleural and septal thickening, this alveolar prognosis, a question of whether there was some peripheral eosinophilia and some of these tocilizumab reactions, as well as some other features as well. Whereas other things, such as pulmonary hypertension and some rashes that were seen in this, didn't really seem to be as associated with biologic pretreatment. So let's talk a little bit about our experience with these children in our clinic at Cincinnati Children's. So we see them in a multidisciplinary clinic, which on the rheumatology side is seen by either myself or Alexi Grom, and then together with my pulmonary partner, Chris Tao, who runs the rare lung disease program at Cincinnati Children's. And you can see that since about 2015, we've been seeing increasing numbers of children every year with new evaluations for suspected systemic JIA lung disease. And we've now seen over 30 patients cumulatively with systemic JIA lung disease. Total of 33 as of this summer, I believe. Most of those were second opinions that were seen at Cincinnati Children's after lung disease were detected, including a couple patients who are primarily followed by Dr. Habde and Dr. Rascala here in the Twin Cities. However, 5 of these patients were ones who were sort of in our local cohort at Cincinnati, who were diagnosed and managed there before lung disease detection. So a fellow who looked at our local population, we followed about 74 patients with systemic JIA locally at that time, which suggests that the prevalence of lung disease could be as high as 6 or 7%. So 1 in 20 or more of children with systemic JIA, which is quite a number given the significant mortality and morbidity associated with this condition. So some of the clinical characteristics, this is from off the first 27 that we saw, and then Shima Yazin, who's just a recently finished clinical fellow at Cincinnati, did a case control study where she then matched these by current age and sex to 2 children who did not have lung disease. What we see is relatively equal male and female prevalence. But a relatively young age of SJIA diagnosis with a median of 2 years. And the proportion of those who are under 2 years was significantly higher than our controls with an odds ratio of 6.5. Again, diagnosis of lung disease about 2 years after that SJIA diagnosis. Almost all of them have some history of macrophage activation syndrome, which is remember I said that even sort of the subclinical MAS is only usually seen in about 1/3 or so of children. So episodes of MAS had a very high odds ratio for lung disease. All of them that we had seen there had been on biologics at some point in their course, which was really no different from our overall cohort. That's really become the standard of care at most large rheumatology centers for early use of biologics in these children. However, what we did see was that over 40% of them had some adverse event to biologic treatment, which we defined as anything that caused them to stop taking the medicine. Most of those were infusion-type reactions to tocilizumab, but some of them were rashes or hepatitis in response to anakinra. We also look at serum Iliotine, which is a marker. So it's an IL-1 family cytokine that's produced by inflammasomes and high in at least a subset of autoinflammatory diseases, particularly in systemic JIA and some of the monogenic inflammasomopathies. And we see significantly higher levels of Iliotine in children who develop lung disease. And also similar to the Stanford cohort, we see A little bit more than 10% of these patients have trisomy 21. So it's interesting, trisomy 21 children, as you know, have a high risk of autoimmunity. But again, this isn't an autoimmune disease, this is an autoinflammatory disease. So and in fact, in the CARA registry at that time, out of 200, 300 or so children with systemic JIA in the registry, none of them had trisomy 21. So this seems to be a very peculiar association between trisomy 21, systemic JIA, and lung disease. I had a student who worked in my lab this summer who went and looked at our overall cohort to look at some of their long-term outcomes, given that the two large series, the CARA series and the Stanford series, both showed pretty significant long-term mortality. Our cohort, thankfully, has overall done better. At 500 days out, we see 90+% survival, which obviously is not great, but is better than 50% mortality, which has been reported in some of the prior series. However, if we looked as a secondary outcome of need for oxygen supplementation, we saw that over a third of them did require some chronic oxygen or other respiratory support at 500 days. So still very significant morbidity related to this lung disease. Just a little bit on sort of the chest CT features. I'm not a radiologist or a pulmonologist, although I'm sort of becoming one of them. But I think we can kind of break these down into things that we frequently see in lung disease, that are commonly seen, and things that are rarely seen. So the most common things that we see are this sort of pleural bronchial wall and peribronchovascular thickening and sort of septal widening, which pathologically we associate with some of the interstitial inflammation that I'll show you in just the next slide here. A large number of those patients will also see some ground glass opacities, lymphadenopathy, and then peripheral consolidations, which we're seeing more here on the panel C, the one on the right, a more severely involved patient. And then rarely seen, but in some of them we can see some pulmonary artery enlargement correlating often with pulmonary hypertension, some tree and bud opacities, some nodular opacities, and pleural effusions. My student Yan Hong also this summer looked to see, are we more likely to see some of those findings in those children who have a more severe course and require home oxygen? Again, it's a relatively small n, so none of these were significant, but we do see higher levels of patients needing oxygen supplementation in those who have those tree and bud opacities, those ground glass opacities, and particularly a pulmonary artery enlargement, which most of them have either subclinical or overt clinical pulmonary artery hypertension. So histologically, what we see is very interesting. So in the upper left, this is for the gross picture, and what you can see is that this is a very sort of patchy infiltrate where you see areas of grossly abnormal lung next to areas of grossly normal looking lung. And below that here, you can see the same thing histologically, where you see other areas which look great, right? Lots of white, good airspace next to areas that are really socked in. If you look a little bit closer, you see a couple of main features. One is there's this degree of interstitial inflammation, which we'll show in a second. But one of the other things you see in the bottom is this sort of proteinaceous material, which is sort of on a spectrum of endogenous lipoid pneumonia to pulmonary alveolar prognosis. So this filling of the alveolar spaces with this proteinaceous material. We also see varying degrees of fibrosis and vasculopathy. The interstitial inflammation, we see this as a mixture of B and T cells. So we see lots of staining for CD3 cells. We see scattered B cells, CD20 B cells, as well as these sort of more islands and consolidate and foci of B cells. For our T cell subsets, we see primarily CD4 cells, but we also see CD8s in the lung as well. And the ratio of that, sometimes they're fairly equal, sometimes it's sort of a CD4 predominance. So let's talk more about this alveolar prognosis. So as I noted, the air spaces in most of these biopsies are filled with this sort of granular lipoproteinaceous material, as well as foamy macrophages. And really that material is thought to be surfactant. which is very similar to pattern to what we see in the disorders of PAP, or pulmonary alveolar prognosis. So what is PAP? So PAP is sort of a large collection of disorders which share this feature of accumulation and filling of the air spaces with this protein called surfactant. And that can be for a number of different causes. So there's congenital PAP, which is due to genetic defects in surfactant production. Some of those were first described by my colleague Jeff Whitsitt here at Cincinnati Children's. And then there's the primary form of PAP, which is due to disrupted maturation of alveolar macrophages. So particularly through the GM-CSF signaling pathway. So this can be hereditary. So these are children who rarely present with mutations in the genes encoding the GM-CSF receptor. Or there's also an autoimmune form of this. So this was actually originally called idiopathic PAP and would present in adults. But it was actually found that those patients have high titer autoantibodies against the GM-CSF receptor, which prevent the normal development and maturation of alveolar macrophages. And you treat them with immunosuppressives, as you do in other autoimmune diseases. And then, of course, there's a primary PAP, there has to be a secondary PAP. And the secondary PAP is sort of a whole gamish of different disorders which affect either the number or the function of alveolar macrophages. So taken together, what all of these do is, they share is this sort of impairment in the normal maturation through GM-CSF of alveolar macrophages. So in primary PAP, GM-CSF binds to the GM-CSF receptor, signals through the JAK-STAT pathway to activate a number of features of maturation in alveolar macrophages, particularly activating the phagocytic and phagolysocytic system, which engulfs and recycles surfactant. Remember, pulmonary macrophages, or alveolar macrophages, are sort of the garbage disposals of the lungs, right? They keep things clear, they recycle that surfactant, keep things lubricated. Now, if there's a problem, right, there's mutations in that receptor, mutations in some of the signaling downstream of that receptor, or autoantibodies that block that maturation, you see a failure of that phagolysosomal recycling and degradation, and then a buildup of that surfactant. So, is systemic JIA lung disease, is it a form of primary? Do these patients really just have primary or congenital PAP? We don't think so. So we looked at a number of things. First, we looked at genetics. We've done whole exome sequencing on about a dozen or so of these patients. We haven't found any pathogenic mutations in the genes that are associated with hereditary or congenital PAP. Is this autoimmune PAP? Well, no. So we've actually looked now through, together with Bruce Trefnell and his group here at Cincinnati Children's, at about half a dozen of these patients to look to see, do they have these anti-GM-CSF antibodies? Here on the left, you can see as a control, those are patients who have autoimmune PAP. They have high titers of those. Patients with hereditary or genetic PAP don't have those antibodies. And our systemic JIA patients similarly have low to undetectable levels of those antibodies. So no, this isn't an autoimmune PAP. And then, is there some sort of an unrecognized functional problem in the myeloid cells in these patients? So this is a GM-CSF stimulation assay where whole blood is taken, incubated with GM-CSF, and we look for STAT5 phosphorylation in response to GM-CSF. And we see these sort of GM-CSF dose response curve here. The blue lines here are controls that were done concurrently with 4 different patients with systemic GI and lung disease. And we see really indistinguishable responses in STAT5 phosphorylation. So these are able to respond. There's not an intrinsic defect in the myeloid lineage to respond to GM-CSF. So if it's not primary PAP, what is going on in the lungs? So a couple of interesting things we find when we look at the BAL fluid. So in the primary forms of PAP, autoimmune and hereditary PAP, we see a very high percentage of those macrophages that they report as being lipid laden. So sort of chock full of all that proteinaceous material, which, as we were showing a couple of slides back, is able to be ingested but not able to be successfully degraded because of that ineffective GM-CSF system. In our patients with systemic GI and lung disease, it's more variable, but as a whole is significantly lower levels of lipid-laden macrophages than we see in primary PAP. The overall cytology that we see is largely similar, with usually a more macrophage predominance, although we do see some patients that have a sort of a neutrophil predominance, which we don't fully understand, but appears to be linked to sort of disease progression. And then we perform cytokine profiling on the BAL fluid. And we see a couple of interesting things. One is that patients with systemic GI and lung disease almost universally have high levels of IL-18 in the BAL, which goes along with what we see in the periphery with very high levels of IL-18. And that's significantly higher than what we see in those patients with primary PAP. This isn't just a general reflection of the systemic inflammatory activity of these patients, because if we look at other pro-inflammatory cytokines like IL-6, IL-8, TNF, those are not elevated in the BAL. And then if we look at a couple of chemokines that are interferon gamma-induced chemokines, CXCL9, CXCL10, what we see is that there's a subset of patients that have very high levels of interferon-induced chemokines in the BAL. Not all, but some. And then we wanted to look at the lung tissue more directly. And so we performed some transcriptional profiling of lung biopsy tissues using a nanostring platform, which is able to do multiplex transcriptomics on FFPE biopsy tissue. So we compared 8 biopsy samples from children with systemic GIA to 3 what we sort of healthy control lungs. And we obtained those from our colleagues in the lung transplant program. So these were donor lungs that were ultimately not used for transplant, and instead have been used for research. So probably the healthy-ish looking lung tissue you're going to find sort of ex vivo. When we did that, we found a number of genes that were upregulated in systemic GIA lung disease tissue compared to controls. And kind of 3 big groups that we saw. One was that they have very high expression of some HLA genes, class 2 MHC genes, which can be a sign of interferon gamma activation. We see a number of genes that are in the interferon gamma signaling and response pathway, including our cytokines of CXCL9, CXCL10, that are significantly upregulated in the lung tissue. And then finally, several genes that are linked to T cell activation, CTLA4, the IL-2 receptor itself, compared to control lung tissue. Interestingly, while we see this very strong separation of these from control patients, we included in those 8 2 lung biopsies that were relatively unaffected, these ones that have the sort of UN or UN annotation. And those really clustered with all the other lung tissues, suggesting that we're seeing this transcriptional response in the lungs really all throughout the lungs, not just in areas with sort of significant histopathological changes. So this has sort of allowed us to begin to construct a model for what we think is happening in lung disease. So we see this sort of systemic cytokine storm in systemic GIA and MAS. And MAS, particularly in those systemics, is driven with very high levels of IL-18, which then drive this interferon gamma response. This then may activate those resident alveolar macrophages in the lungs, leading to the sort of Th1 type response, and ultimately leading to sort of the self-sustained interferon gamma-driven Th1 response in the lungs, which we see with production of CXCL9 and 10 in the lungs, and an increase in those chemokines in at least some patients in the BAL. This sort of chronic Th1 interferon gamma-driven activation, we hypothesize can affect then alveolar macrophage maturation and leading to this phenotype of pulmonary alveolar prognosis. A lot of questions to this, right? So is there a role for these biologic agents? So as we noted, this disease was really not reported in the pre-biologic era, and almost all patients with lung disease are now being seen after they've been treated with these biologics. So does this feed into these pathways somehow? There's also this question of reactions to these biologics. Could it be not so much the drug itself, but some sort of a hypersensitivity reaction to these drugs that's feeding into these pathways? Again, whenever we treat 100% nearly patients with these medicines, but 5 to 10% of them are developing lung disease. So whenever we see something like that, we wonder, well, there's got to be some other trigger. So there are genetic factors that we haven't been able to identify yet. Is there some other environmental factors? We also see different areas of the world where we see more of this lung disease and areas where we see a lot less of these lung disease. But really, we can see anytime there's a model with this many arrows and this many question marks, you know that it's probably wrong. So this is sort of our beginning of our working model, but I doubt that we're right. So with this, then, we're left with the question of what do we do for these children, which is often why we're seeing a lot of these children for second opinions. And we have kind of three main tenets in our management approach. The first is to try to prevent lung infections. It seems that many of these patients seem to have a precipitous decline in conjunction with an infection. We treat them with prophylaxis for pneumocystis. We aggressively treat any concern for pneumonia or other lung infections. And many of them require some amount of airway clearance when indicated to help, again, keep things moving and doing some pulmonary toilet. We think that controlling the underlying disease activity is crucial. And we think that because we have a number of patients who have been diagnosed with lung disease, have had a good response to a biologic treatment, and have not seen progression of their lung disease, and in fact really seen resolution of their lung disease. And the only sort of shared feature is that we were able to find a treatment regimen for them that could control their disease. So many of these patients are on biologics, but it doesn't seem to be fully effective. They still have systemic inflammation. I think I don't support sort of stopping biologics carte blanche, but I think that if it's an ineffective biologic treatment, we need to find something else. And similarly, there may be a role for them targeting those interferon pathways to help control that overall inflammation. And potential sort of options that are in evaluation: tofacitinib is in phase 3 trials for systemic JIA, and mepalimab is in a phase 2 trial for acute MAS. And there's consideration for both of those of trials in lung disease. And then doing things that our pulmonary colleagues normally do for treating sort of connective tissue disease related to ILD. So other medicines that are more T-cell targeting than things we normally use in systemic JIA, like MMF, like abatacept, azithromycin, which is of course an antibiotic, but also has anti-inflammatory activities. And we had some patients where they're on inhaled corticosteroids. But really, what we need to do is better understand the disease itself and what's causing that. So I'll spend the last 5 to 10 minutes here talking about some new data in our lab using a mouse model of MAS, implications that may have for this disease. So there are several mouse models that exist to try to model the systemic hyperinflammation that's seen in systemic JIA, and particularly in macrophage activation syndrome. Most of them require some amount of genetic manipulation, which again is sort of an artificial system given these patients don't have known single gene mutations. But none of them have reported to have lung involvement. The best characterized of these models is a non-genetic model, which is called the TLR9 model, where these mice are given repeated injections of CpG as a toll-like receptor agonist. They're given 5 injections over the course of 10 days to induce sort of a state of subclinical MAS. So what we see in that model really reflects a lot of those features of sort of smoldering systemic GIA subclinical MAS. So we see some degree of lymphopenia, anemia, and thrombocytopenia, which are sort of the early cytopenia features we see in MAS. Very significant splenomegaly. The top there in B is a normal mouse spleens, and then these are these MAS mouse spleens that are sort of 3 to 5 times their normal size, and some degree of hyperferrotemia. If we look at the serum cytokine profiles, we see the beginnings of this cytokine storm with high levels of a number of cytokines and chemokines, including IL-1, IL-6, TNF, IL-18, interferon gamma itself, as well as those interferon-induced chemokines, particularly CXCL9. So then we decided to try to look at the lungs very carefully to see what we see. And what we saw was interesting. Very subtle and scattered pulmonary inflammation. It was not sort of raging, but we would see this sort of interstitial peribronchovascular lymphocytic infiltration. which again, CD3 positive with some amounts of B cells, but primarily T lymphocytes, particularly in these sort of perivascular areas, which is interestingly very similar to what we see in the pattern of involvement in systemic GI lung disease, where we see this patchy pattern of sort of perivascular involvement. If we take this lung tissue and digest it for flow cytometry, we can see a significantly increased amount of CD3 cells in the lungs, and particularly our CD4 helper cells, without really a change in the number of CD8 cells. And then if we take that lung homogeneous and do cytokine profiling, what we see is particularly an activation of interferon gamma and those interferon-induced chemokines such as CXCL9 and 10, along with some other T-cell chemoattractant chemokines like RANTES. Interestingly, other pro-inflammatory cytokines that we see systemically in this model, like IL-6, TNF, IL-12, we don't see those at all elevated in the lungs. This is really specific for interferon gamma. And then we looked a little bit closely at the alveolar space and the alveolar macrophages. We don't see any increased number of alveolar macrophages in the BAL, but what we do see is those same chemokines and cytokines being increased in the BAL fluid. We see a slight increase in interferon gamma, but a more robust increase in those interferon-induced chemokines like CXCL9 and 10, as well as an increase in IL-18 in the BAL fluid. If we take those alveolar macrophages out and look at them by flow cytometry, we see an increase in MHC class II expression, which can reflect interferon gamma activation, which is again similar to what we saw in our patient gene expression studies. If we then culture those alveolar macrophages ex vivo and look for chemokine secretion, we see secretion of those same chemokines such as CXCL9 and 10, IL-12 itself, and MIP1 alpha from alveolar macrophages from MAS mice compared to control mice. And finally, if we look transcriptionally at those alveolar macrophages, we see an increase in interferon gamma type 1 response genes such as IL-12 and CXCL9 without changes in things like TGF-beta or hemoxidase, sort of more M2 resolution type genes. We then wanted to look at the whole lung to see sort of how extensively we're seeing these transcriptional changes. So we performed single-cell RNA-seq on a mouse with acute MAS compared to a control mouse. When we look at those together, we see about 30 different cell populations that we can identify transcriptionally. Lymphoid, myeloid, lung parenchymal cells, all included. The main change that we see between those is this massive expansion in the myeloid compartment, which you see, I don't know if you can see my cursor here, but in the upper right of the MAS plot, you see this big expansion of the myeloid compartment of alveolar macrophages, inflammatory monocytes, compared to the rest of the cell populations. If we look at those more carefully, we've taken an approach called cell harmony, which sort of aligns the cell populations between our sample of interest and the reference control sample. We see a large number of upregulated genes across these different cell populations. Most of those genes were cell type specific. However, what we did see was shared across many of these different cell populations was an activation of an interferon response. General interferon signaling, interferon gamma in some of these, as well as antigen presentation and antigen processing. So across multiple cell types, including lymphoid cells, NK cells, macrophages, lung epithelial cells, and endothelial cells, all of them displaying this interferon activation. Finally, we looked with this model at what happens when that MAS is resolved. People mainly use this model to look sort of acutely at what happens during MAS. But we let these mouse recover for about 3 weeks after MAS and then looked at their lungs. And what we saw was actually much more extensive inflammation in the lungs compared to what we saw at baseline. Much more frequent and pronounced of this T-cell infiltration, including some sort of clusters of lymphocytes that we see that are again sort of analogous to what we see in our patient biopsies as well. We then looked transcriptionally at what we see in those alveolar macrophages. So we isolated alveolar macrophages and performed microarrays to look at their transcriptional profile. In acute MAS, which is shown here in the blue samples, we see activation of a large number of genes, which are particularly in those interferon gamma response pathways, as well as a number of other immune pathways. However, if we compare those to then our resolution phase macrophages, what we see is much more extensive transcriptional changes associated with resolution, which are somewhat overlapping with those changes we see in acute MAS, but much more extensive. And performing pathway analysis on those, what we see is a number of different things. On top is our upregulated genes, so we see large metabolic changes in these alveolar macrophages, regulation of metabolic processes and biosynthetic processes. Our downregulated genes, primarily sort of those immune response genes, or cytokine production genes that are being downregulated as those macrophages reach the sort of M2 resolution phenotype. So putting those together to try to kind of make a hypothesis about what might be happening. When we look in the mice, we see interstitial inflammation that's lymphocyte predominant, perivascular, somewhat analogous to what we see in our patients, but we don't see alveolar prognosis. However, there's a couple of hints that we have that, that may suggest that we're on the right track. So we know from prior work that in mice that have a T-cell restricted overexpression of a transcription factor called TBET, which really drives Th1 differentiation and interferon gamma production, those mice in the lungs get PAP. So that's shown here on the right. This is a wild-type mice, heterozygous mice, and then those with homozygous TBET overexpression. You see really significant amounts of hemophagocytes, of alveolar prognosis in the lungs, and you also see hemophagocytosis in the bone marrow. Interestingly, our resolution phase alveolar macrophages also induce a transcription factor called BOC1, and it's been shown that BOC1 deficiency in mice can worsen certain forms of PAP. So together, this could support a hypothesis where persistent interferon activation from a state of chronic recurrent MAS or smoldering MAS, as we see in some of our patients, could prevent that activation of that resolution phenotype, causing macrophage dysfunction, leading to alveolar prognosis. And so those are the kind of the ongoing focus of the studies of this in our lab. So in conclusion, systemic GI lung disease really represents a novel inflammatory lung disease, which has distinct radiographic pathologic features, including alveolar prognosis and this ongoing and chronic interstitial inflammation. There's been increasing recognition of this, which is temporarily linked to the use of anti-cytokine, particularly IL-1 and IL-6 therapy. In general, these patients lack evidence of primary congenital PAP on a genetic, serological, or functional basis. However, our translational work showed that there's substantial inflammation, including elevated IL-18 and interferon gamma pathways in the lungs of these children. And our mouse model of MAS demonstrates interstitial inflammation and interferon gamma-driven alveolar macrophage activation, followed by persistent inflammation during MAS resolution. And then our hypothesis, which is that persistent interferon gamma activation and a failure to resolve pulmonary inflammation could lead to alveolar prognosis. Many acknowledgements and thanks here. People in my team who did a lot of the work, particularly Denny Gao, who is leading our mouse model work, Shimi Yazine, who did the case control work, Donna, who processes most of our translational samples, and then Yan and Huang, who have helped with this follow-up study this summer. My colleagues at Cincinnati Children, particularly Alexi Grom and Chris Tao, our collaborators at Pitt and at Stanford, and our generous funding sources who help us keep the lights on here. And then I'd be very happy to take some questions here in the last few minutes. I see one question in the chat box, which I can try to address first, from Gail Brotman. Typical CTs and PAP show this crazy paving pattern, which we don't usually see in systemic JIA. Yeah, that's a great point. So we don't know exactly why we don't see that pattern typically. You know, again, I think it comes back to the fact that while there is alveolar prognosis, the overall pathology in the lungs is very different. You see much more extensive interstitial inflammation than you see in the primary forms of PAP. And similarly, in general, we're not able to mobilize a lot of this prognaceous material by BAL. Many of these patients come to us, they've been bronched, they've been told they don't have PAP because they got a bronch and it didn't come up with that like milky, cloudy, prognaceous fluid. But if they ultimately get a biopsy, you see this PAP-like pattern. Interestingly, some patients with systemic JIA will have that pattern. There's actually one, a patient of Dr. Habde's who we've seen as well, who did sort of develop more of that kind of crazy paving pattern along with worsening oxygen requirements. And she actually did mobilize a ton of fluid and did really well with a whole lung lavage. But in generally, most of these kids don't really get much benefit from whole lung lavage.
Grant, there was a comment there from our head of pulmonary as well, and I have to concur. And then I don't know if you can see the chat function. There are a couple of questions, a long one from your friend Bryce and another from our director of our cytokine lab. Can you see those?
I can see the question and answer here, which I'm seeing a couple.
Rich, why don't you go ahead and read the question?
So I'll give you the short one first, which is how important is it to routinely monitor cytokines in these patients and how frequently? That's become the theme of our year here dealing with COVID-19.
Yeah, and actually I was gonna make a joke that I'm really excited to give this because this is the first talk I've given in a long time that isn't on COVID. Clinically, we're still trying to understand the best use for sort of cytokine panels in these children. It seems very plausible that would help you guide therapy, right? And if you find elevated mediators, you target those mediators. That's not necessarily been the experience. There's a couple of things that we do find that is helpful. We do check Iotine levels at least periodically in these children because it seems that patients with high Iotine are more at risk for some of these interferon-related complications, both MAS and lung disease. Again, we showed here the data on lung disease, and then Dr. Yazin published a paper in 2018 showing that high levels of Iotine are associated with patients who have a history of MAS. So I think that may have some role, but it's very slow to change. We in Shima's paper, she also showed there was no correlation at all between time and remission and the level of Iotine. So it decreases very, very slowly, but it's not linear in any sense of the word. The other cytokine that we think is helpful to follow is these sort of S100 alarmin proteins, which I guess are not true cytokines, but they're alarmins. So S100 A8, A9, or calprotectin, A12, or calgranulin C. Those are pretty specific markers for monocyte and neutrophil activation, respectively, which we see as very high in a lot of our autoinflammatory diseases, including systemic JIA, and are good markers for subclinical disease. And there's been some studies in JIA, both systemic and broadly, showing that they're good markers to check before stopping therapy. Rich and I, a couple years ago, were part of a CARA project looking at how you stop therapy in systemic JIA, and there's a lot of interest in biomarkers that can help guide that. And there's at least some data that when those cytokines normalize, you're more likely to do well after stopping therapy.
We're running over, but I thought maybe we could fit in one last question, which is from one of our geneticists about the enrichment of trisomy 21.
Yeah, that's a super interesting question, right? So there's a couple of hypotheses. The initial hypothesis was maybe having to do with some aspiration and whether, those children, if they have sort of chronic microaspiration, that could be another hit that's helping with this. But of course, that doesn't explain why they're getting this sort of inflammatory disorder in the first place. There's also been some really interesting work that's been coming from mainly the folks in Colorado at inflammation and particularly sort of interferon-driven autoinflammation in children with Down syndrome. So on chromosome 21 is actually a lot of interferon-related genes, including the interferon receptors, and that they seem to have sort of a low-grade interferonopathy, which may relate to both their broad risk for autoimmunity as well as their risk for inflammatory diseases such as systemic JIA. But those are complete hypotheses with very little data.
Okay. Well, thank you so much. That was tremendous.
Thank you guys for asking me, and maybe sometime I'll get to do and actually get to visit you guys in the Twin Cities.
That'd be
That would
good.
be great.
Thank you very much, Dr. Schulert. Nice to meet you.
Thank you all.